So to our keynote speaker, Professor Kamaldeep Bhui is a prominent figure in the field of psychiatry, currently serving as a Professor of Psychiatry at the University of Oxford and Senior Research Fellow at Wadham College. He is also an honorary consultant psychiatrist at the East London NHS Foundation Trust and Oxford Health NHS Foundation Trust. Cam is recognised for his contributions to mental health research and practice, particularly focusing on issues related to race inequality and social justice in mental health care. He leads the Chimes Collaborative, which integrates creative arts and social science into mental health research. His current research includes examining the impact of adverse childhood experiences on mental health and co-designing digital interventions to address racial disparities in mental health. In addition to his research, Cam holds roles such as Editor-in-Chief of the British Journal of Psychiatry and serves on various boards, including the MQ Science Council, where he is involved in advancing mental health research. So Cam, I'm going to pass over to you.
Well, thank you very much for the very kind introduction and also for the invitation to speak. Thank you to Stephen, Suzanne and Gary for keeping me connected and tolerating my disciplinary differences. And this is one of the joys of this meeting, is we are exchanging views and finding out about things that none of us really fully understand. And that's quite a courageous thing to do and difficult space to get into. So I came into this through BioAirNet. You may be wondering what on earth a psychiatrist is doing in this space. And I'll talk a little bit about that experience as well as I progress. I start just with a brief introduction around causality. You know, we're dealing with very complex brain systems and complex body systems and really complex social and environmental systems. And so as soon as we start talking about data, notions of and questions of causality arise and contested causality. And of course we find this in the interdisciplinary space. Something you consider cherished and completely proven in another discipline is contested and considered snake oil. So that's one of the experiences that we do have to manage as we go along. And I wanted to put that up front, that many of these dynamic, mutually constitutive environmental and social systems shape health over the life course. So we're not in an easy space, yet I'm going to try and simplify some of the data. And more importantly, I think there's sufficient emerging data on mechanisms and risks for brain health for us to take notice despite those caveats and cautions. I'm a social and cultural psychiatrist. Although I did a pharmacology degree many years ago, I went over to the other side really very soon because I saw what made a difference in people's lives. This is a beautiful picture from the Foresight report in 2008, which was the first time the government tried to properly understand wider influences on mental health and brain health. And although it's complicated, it's still not complicated enough really for what goes on. Within there are etiological factors, which are also preventive opportunities. There are things to do to recover. There are things to do which make life worse for you. And it attempts to bring in a number of influences, for example, adverse childhood experiences, social exclusion, poverty, the sorts of things Michael was talking about yesterday, and life events. Notably, air quality is missing from that, and that's really been the purpose that I hope I'm serving and will continue to serve in BioAirNet and in other activities. This is my schematic of trying to introduce that to some of the audiences I present to and some of the papers I publish. I'm taking an eco-social, cultural, syndemic lens and trying to integrate these different frameworks. Each of those have a different history, a different trajectory, different champions, but I'm trying to look at all of those in combination, particularly when trying to explain inequalities in health outcomes and mental health outcomes, and particularly ethnic inequalities in mental health outcomes. In London, we have some of the highest rates of schizophrenia in the world, and we don't quite know why. So urbanisation has got something to do with it, but air quality has never really been properly considered. So I'm going to present some data to you to persuade you, I hope, that this is an important area to look at. This model is interesting because it brings in adverse childhood experiences, and you may wonder, well, what are the mechanisms here? Of course, there are social mechanisms, there are psychological mechanisms, but there are also biological mechanisms at play. Inflammation in particular, I think, is very important. Young people exposed to maltreatment, trauma are more likely over the life course to develop neurodevelopmental disorders, depression, take more alcohol, substances, be incarcerated, and have depression and psychosis. And indeed, if you have more than 4 to 6 adverse childhood experiences, you have a shortened life expectancy by 15 years or so. So it's this sort of separation of the biological and social is a fallacy. That's my key message, really. And we need to be thinking about the interacting mechanisms that lead to poorer outcomes. And air quality and air pollution is therefore a very important contributor to that whole history. Now, this is important also not only for prevention and science, but for clinicians. When they see someone with a mental health problem, they've got to be what's called structurally competent. They've got to be aware of the housing and damp and the poverty and the gangs in the neighbourhood and the ease with which you can get substances. Just treating an individual as an embodied individual who is lacking a neurotransmitter isn't really going to be very helpful. Hence my attraction into social and cultural psychiatry over the decades and looking at risk factors like identity, cultural identity, explanatory models and beliefs, as well as the more conventional factors we look at. The work of BioAirNet that I've been involved in is published in 2 papers in BJ Psych Open, so I'm not going to spend a lot of time referring to references, but if you want to look at it, these are the 2 papers, one of them out just very recently. And again, that's been a very interesting interdisciplinary experience of whichever journal you send it to doesn't really want it because they either think it's not within their scope or they think it's well known or they think this is all snake oil, they don't really understand what you're doing this for, why are you connecting these different disciplinary dots when you can't really substantiate the basic science in one area or the other yet. So it is a different form of science, and I would argue this is the form of science that's going to be attractive to policymakers and politicians because you're presenting, you have to do it in a simple format. You have to convey what are the big points here that will change health over the life course. And so I take the notion of an exposome as the way forward, including air quality, but also geographical space and the built environment, geopolitics, social variables, housing, as well as racism, stigma, discrimination, crime. Even racism as a social factor is associated with a higher incidence of psychosis, for example, and depression. So these social factors that affect our everyday lives aren't simply trivial. They are public health crises of a sort. And they interact with other noxious environmental toxins like air pollution. And so you're living in a poor area, you're living in a noisy place, you're living in a place where there are lots of gangs, and you've got poor air quality. It's no surprise you're going to have multiple health problems over the life course. Physical health and mental health show reverse causality, so even the distinction between does this cause a mental health problem or a physical health problem is fallacious, really. They show reverse causality. If someone with depression, cancer develops depression, you treat their depression, it reduces their mortality over a period of time, gives them a bit more time to plan, perhaps, what the end might look like, and vice versa, that people who have depression are more likely to have other physical health problems over the life course. Depression is an interesting problem. It includes pessimism, poor self-care, lack of motivation, and it compounds adverse conditions like poverty and lack of social support. People who are depressed or have neuromental problems aren't very good at repairing relationships, for example. The very thing they need, social support, is the very thing they find difficult. So they end up being isolated and don't benefit. Poverty and food scarcity impact on cognitive decisions, making the brain vulnerable to poor air quality. Poor housing, fungal exposures, direct and indirect through respiratory tissues, can affect your health. We know people with severe mental illness have impaired lung function already, and if they get respiratory disease on top of that and they have poor air quality around them, it's a problem for them. The climate change data is also interesting. We know people with severe mental illness also have poor temperature regulation, so as the temperatures go up, they're less able to regulate their temperature. And of course, the poisonous drugs we give them impair their temperature regulation even more. So this is a real issue for clinicians as well as public health in terms of how we will face the climate change in the future. There's lots of evidence around adversity and poverty causing inflammation. I'll say that again in case you haven't come across that trauma, adverse environments are inflammogenic. They generate inflammation in the body, and that's the mechanism I'm particularly interested in, although I'm not a biologist. It means talking to lots of people in those spaces. I'm going to skip that because I've covered all of that. So this is from BioAirNet. These are all the sources of air pollution and by aerosols that we have to contend with. And what we're trying to do is look at these complex systems across all these different venues and geographical spaces and conditions, and think about policy interventions and individual interventions and health service interventions. More specifically, we know that particles can enter the brain through the olfactory bulb. There's some evidence of that, particularly ultrafine particles through the nasal epithelium. And that affects, if they go into the lung, it affects your respiratory tissues. There are cytokines released which can affect brain function. So systemic inflammation can affect brain inflammation. This is a more complex picture that Stephen kindly sent to me, and I thought it was worth showing because it begins to add other layers of complexity, feedback loops between this nervous system and the brain, the blood-brain barrier, other sorts of influences, and cellular activity as well, and microglia, and how these different mechanisms will need to be investigated and explored in the future, but we mustn't lose sight of the big picture of what we're really trying to do in the process. So I'm sure all of you brilliant scientists will be tackling one or other bit of this mechanistic pathway, and it's only by connecting all those dots that we'll be able to make progress in the future. This is a schematic taken from one of the papers that I talked of earlier, and even getting it across reviewers' comment was challenging, trying to explain how air quality might affect the mind, the body, and the brain was difficult, and I came up with this schematic to show that you can get brain inflammation and systemic inflammation, and both lead to long-term mental health conditions, and as well as multiple morbidities in terms of physical health conditions. That's a very simple schematic, but that was really hard to get across to reviewers and journal editors and colleagues and other scientists. So it's kind of the challenge we have. We have to simplify our models to some extent, but at the same time show some humility in terms of causal inferences and what we're trying to do in this space. Stephen very kindly invited me to contribute to the Royal College of Physicians report. And so that's been a really exciting opportunity as well to lay out the importance of brain health and the implications for brain health when thinking about air quality. I've summarised the next 7 slides here, so I'm not going to go through every slide, but there are a couple I just want to dwell on, and I was aware there may be time limitations, so I will try and economise a little. There's sufficient evidence, in summary, to show that depression is associated with PM2.5, high levels of that. There's a little less on psychosis, but there is evidence that in high polluted areas, the incidence, the new onsets of psychosis are elevated. So it's not just an exacerbation of existing illness, it's also new onset cases. But there is evidence also that people relapse more often. I don't really know how that happens or why, and we're trying to explore that, but there's enough epidemiological data beginning to show that. It may be the mechanism is through physical health problems, respiratory problems, because there are reverse causalities. I'm not sure. There's enough evidence of neurodevelopmental disorders, autism and ADHD also, for us to really be concerned. And we know neurodevelopmental problems are really challenging. We know people with neurodevelopmental problems also are feeling the intensity of traumatic events around them much more than people who aren't neurodiverse. They ruminate and will have difficulty managing those processes more so than other people. I've mentioned antipsychotic prescribing already. Over the life course, taking a public health approach, there are particular critical periods that we need to be wary of. Obviously pregnancy, adolescence. We know that half of all mental illness, adult mental illness, begins before the age of 11. About 3/4 before the age of 25. So that rapid period of brain maturation is a critical period of sensitivity when horrible things can happen to your health, and they're determined at that point, but they might not appear for decades. Similarly, fetal exposure and maternal exposure. So I'm just going to pop along to those particular areas. We know air pollution is associated with ischemic stroke and neurodegeneration, and there's evidence of direct transmission through olfactory bulbs to the brain. But these are some of the data I was really intrigued by, that children exposed to fine and ultrafine particles already show evidence of the hallmarks of Alzheimer's and Parkinson's disease, namely hyperphosphorylated tau and amyloid plaques and misfolded alpha-nuclein, synuclein. That's extraordinary. If you're living in a high polluted area, the children are already showing evidence of something that might happen to them 30, 40 years later. And we know people who show dementia pathology tend not to show symptoms for decades, and we can't really tell how long it might take for them to develop symptoms. So that's something very important to bear in mind. There's evidence of pregnancy in the early years and exposure to air pollution leading to later mental health problems, and so that's an important thing to think about, particularly if you're living in a poor area, and concerns also about breastfeeding and the environment, the indoor environment that you're dealing with. Adolescence I've mentioned, and it's a Mexico City study in particular that I want you to look up. And you could criticize the methodology, you could say it's a bit sort of ecological. It's just intriguing, and I don't think we can ignore that sort of data without exploring that further. So if you have opportunities to do that, please do pursue it. Neurodevelopmental disorders I mentioned in part already. So heavy metals can also lead to neurodevelopmental disorders, as well as particulate matter and nitrogen and sulfur oxides. Lots of evidence on that, and lots of systematic review evidence on depression, suicide as well, and autism is mentioned specifically. I'm going to draw some conclusions now and dwell on those for a moment, returning to the whole interdisciplinary challenge that we have. So we know there are some associations between poor air quality, both indoors and outdoors. You all know that most people pay more attention to outdoors than indoors, and there's been more interest recently on indoor air quality, and lots of the presentations have been about measuring that and what that might mean. We know that there is a higher incidence of new onset cases in high polluted areas, and whether that's a direct effect or an interaction with poverty, the environment, urbanization is yet to be fully elucidated. There are practical implications because there are higher levels of admission, and if you know about health service and economics, the highest thing, the most costly thing is being admitted to hospital. And so there are economic models that we could develop to look at how to reduce costs to the health system if we can reduce air quality. Thinking of other arguments to make to policymakers and politicians. Critical periods are really important, so if you have any longitudinal data or you can get hold of it, or you want to generate cohorts, longitudinal cohorts are the way forward here. They're expensive, they take time, but it's important to do, particularly given the devastating impact of dementia, which is increasing, and the devastating impact of childhood mental illness, which is a chronic condition which will affect you over the life course, will affect your life chances, your education, will lead to costs in prisons, will lead to costs in health systems, will lead to all sorts of additional costs. So the economics also stacks up if you start looking at children. I heard recently there's also been an elevation in levels of Parkinson's disease post-COVID. About 150% was reported. Thought to be some viral etiology rather than genetic etiology. So there's some very interesting and exciting things happening in the space, although slightly morbid when we think about the implications for human health. And Michael's data showed yesterday what a situation we're in terms of persuading policymakers and politicians to do the right thing. So I also want to make a plea for reverse policy decision making, that communities themselves are equipped, particularly when I'm thinking about marginalised, multiply marginalised communities whose identities you can't even describe because they wouldn't share that view with you. And trying to get them involved, get the messages to them, and allow them to develop local policies and actions that they can take personally rather than waiting for policymakers and politicians to make universal interventions overall. And that is working in some spaces. I know Liverpool, for example, there are projects looking at streets deciding how they run their local services, neighbourhoods and areas, and people coming together. So the more devolution, the better. Obviously, there's an expense issue, there's a cost issue, but it's possible to do that. But it's the only way, I think, to really make sure that what we're offering to improve health is taken up, and it's not only taken up by those who are most able to use it in the least deprived areas, but by everybody, particularly by focusing on those most deprived areas and where there are multiple morbidities. We have lots of critical knowledge gaps that we're all tackling. You've done some incredible presentations on exposure measurement, for example. Equally, there are challenges around mental health measurement and different ways of doing it, using questionnaires or using routine data about hospital visits or prescribing. They all have their pros and cons, but increasingly the NHS is collating data. And so if you can link data sets, please do, and I and my colleagues would be very happy to do so. Although I feel very lonely, there's not a lot of psychiatrists in this space, so If you want to offer some support and friendship to my sort of small campaign, please do, and I'd be most pleased. We do have to use the evidence base cleverly to motivate multi-sector action. In terms of theories of change, what is it that makes things happen? Capabilities, we have to skill up. In my experience, motivation. Pessimism is the worst thing out there really at the moment. That we need motivation, we need optimism, and we need courage to go about doing things. And that's why I've also been working with lots of artists in the creative spaces, thinking about how we communicate our messages, how we gather information from the public without extracting data from them and then throwing them aside while we try and write our papers, but involving them in a creative, pleasurable process, that they get something out of it, that they are known for what they do, but we use the art to emotionally activate people who are too busy. They haven't got the attention span. Policymakers and politicians are busy folks. They've got a difficult job. Too many things hitting their desk on an everyday basis. So we're using arts in that way to also encourage people to become involved. And if you say, I want to sit down and have a serious discussion about air pollution versus come to an art gallery and look at this exhibition, you know, it's a no contest usually in terms of where they'd like to speak and where they're going to feel under pressure. Thank you ever so much. I hope I've stayed within my time limit. These are all the people I want to thank from BioAirNet, but also the wider community from beyond BioAirNet, both on the RCP report, but other people who have just reached out beyond the institutions, all the institutional disciplinary boundaries just vanished in this space. And it's a particularly difficult space to work in and get published in and do work in. So it's worth it. It's going to reach, it's more like your own space, which your institutions might reward, but isn't going to have major public health impacts in the long term. Thank you.